Hello again, and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain, and with me is my brother, Rohit Gosain. Today, we're going to focus on conference highlights from ASH 2024 with a focus on CLL. We've selected three studies: SEQUOIA study that led to the approval of Zanubrutinib, AMPLIFY study looking at Acalabrutinib combination with Venetoclax. That time, let's also briefly touch on ongoing trial called CELESTIAL TN-CLL. And then we'll end with the buzz around CAR-T in this space. To cover all this, we're joined by Dr. John Allan from New York Presbyterian Hospital. John, thank you so much for joining us.
Thank you. It's a pleasure to be here. Nice to meet you both.
John, welcome. Let's get started. Background here for CLL. That is, the choice is either time-limited approach versus lifelong approach. In lifelong, we have BTK inhibitors like Acalabrutinib or Zanubrutinib, or the choice has been in past ibrutinib, but that has fallen out of favor given the side effect profile. From time-limited approach, we have Venetoclax and Obinutuzumab. In community setting, the uptake of Venetoclax has not been that robust because the side effect profile and the supportive care needed with that. With that in mind, let us get started with our first study, SEQUOIA update. This is a study which led to the approval of Zanubrutinib. John, if you don't mind touching briefly on the design and the recent updates, please.
The SEQUOIA study was a large program put on by the company to explore Zanubrutinib in various cohorts of patients. The primary cohort was cohort here, this randomized cohort of Zanubrutinib, 160 milligrams twice daily versus bendamustine rituximab, which was the control arm. Important to note in this cohort, because patients were being randomized to chemotherapy and those patients with higher risk disease features do worse, they actually excluded those patients with 17p deletion, p53 disruption. The larger program of the SEQUOIA had two other cohorts where they funneled basically those patients with 17p deletion into one, a monotherapy approach with just Zanubrutinib, and then one actually with Zanubrutinib and Venetoclax. But the meat and potatoes of this study was this randomized portion, which got Zanubrutinib's approval in the frontline setting. The primary endpoint of the study was progression-free survival, and Zanubrutinib has proven a superior progression-free survival over the chemoimmunotherapy arm of bendamustine rituximab. This study has had several data cuts. One primary analysis data cut, and what we're seeing here was recently published. So this has always been one of the limitations of these second generations drugs, is that their long-term follow-up, paled in comparison to ibrutinib, which had published 10 years of follow-up. I think that argument has fallen away because now 5 years of data is really good data and really gives us a sense of how this drug can stand up against previous comparators. Ultimately, the hazard ratio is 0.29, largely in favor of the Zanubrutinib arm. The bendamustine rituximab had a median progression-free survival of about 44 months, so just less than 4 years, whereas the median PFS has not been met in the Zanubrutinib arm. And at this time point, around this high 70 to 80% range. And that's important to note is that the 5-year PFS for ibrutinib as a historical standard was around 70%. So tracking historically well, meeting the benchmarks that we need any of our BTK inhibitors to meet compared to the drugs that have come before them. And clearly it is doing that. Of interest in the PFS group, we see benefits in the Zanubrutinib arm for both IGHV unmutated and mutated patients. It actually is separating, both of those groups are separating from the chemoimmunotherapy arm. And it's particularly notable that the mutated patients are separating because historically, many times they haven't really differentiated themselves from the chemoimmunotherapy lower risk patients. But that has now started to clearly show a difference at this time point as well. This drug works well for all comers and improves their progression-free survival comparatively to chemo. When you look at the overall survival, this is something we've seen with the bendamustine rituximab studies, is that there actually has never been too many studies, and I don't think any study has shown an overall survival benefit of a BTK inhibitor against bendamustine rituximab. And you could argue, oh, there's an overall survival benefit. Why not use chemo and use this drug? Well, the PFS is so dramatically different. The toxicities are so dramatically different. The toxicity is dramatically different with these agents. There's a strong benefit, even just if it's PFS. And it also shows you just how good our treatments are. These patients are then going on to, in the BR arm, getting BTK inhibitors. They're getting venetoclax-based treatments, and it shows how powerful those drugs are to salvage the patients who progress sooner. If we didn't have those, we may not see this necessarily zero difference between overall survivals. It's something that needs further follow-up to see if these separate, but nonetheless, a positive study for Zanubrutinib and showing the power of this drug, safety of this drug, and impact that this drug is now having on our patients.
John, thank you for going over that. When you're saying chemoimmunotherapy, I want to reiterate the control arm here was BR. FCR has completely fallen out of favor. That is something that we're not using. And then talking about falling out of favor, you touched on ibrutinib having 10-year data in terms of tolerability. We are heavily relying on Zanubrutinib and Acalabrutinib now in this space. In terms of the toxicity being different for BTK inhibitors than chemoimmunotherapy, there might be some overlaps. With Zanubrutinib, we have to worry about hypertension. Acalabrutinib, we have to worry about headaches. John, can you touch on the toxicity profile, the bleeding risk, cardiac side effects, and how are you choosing between one or the other BTK inhibitor available today?
We initially thought that these second generation drugs may really separate themselves in terms of toxicities from ibrutinib. And with time, we've learned that even with more selective drugs, you cannot get away from BTK inhibitor class effects. Those class effects you alluded to, hypertension, arthralgias, rash, diarrhea, atrial fibrillation, bruising, bleeding, can come up with any of these agents, even the non-covalent reversible BTK inhibitors. But nonetheless, with the more selective drugs, we see less percentages of them in any grades, as well as less high-grade toxicities of these specific adverse events of specific interest. And so that has really shifted because we all want to mitigate how many patients with AFib develop. And even if you treat 100 and you can minimize 5 less patients, it's a meaningful impact for that patient as well as for your practice to have to do the referrals and the emergencies that come up with these types of toxicities. And so even though it's a relatively smaller benefit than we might have hoped, it's still enough to say, hey, this is why we need to shift to these drugs in a monotherapy approach. You have to monitor closely for all of these issues. How you differentiate the two drugs, the more selective drugs, Acala or Zanu, is based a little bit on patient preference. Acalabrutinib is typically a twice-a-day drug. There is limited evidence on outcomes on dose reductions. And we do know if you took Acalabrutinib at once a day, you do have less BTK occupancy, and its PK and pharmacodynamic properties are a little bit less than the other covalent BTK inhibitors. Zanubrutinib, though, has in the label this twice daily or once daily option. Patients like that freedom. I frequently use it once a day for those patients who want a once a day, and I talk to them about that approach. There are some differences in while there hasn't been strong data showing dose reductions of Zanubrutinib don't seem to impact an outcome. Based on the pharmacokinetics and pharmacodynamics, the Cmax and the BTK inhibition, even at very low doses, remains very, very high. So I would anticipate, even with dose reductions, we would see similar outcomes compared to patients at full dose. And if anything, we've learned that maybe we have pushed the dose too high on some of these drugs, even like ibrutinib, because we're learning with dose reductions, those patients have similar outcomes than those on higher doses and seem to mitigate some of the toxicities with the drug. Some of these things are actually being explored in future clinical trials with ibrutinib, and even with these agents, it's being monitored closely and evaluated.
Dose optimization is so important. We've talked about Acalabrutinib, but let's take a deeper dive. Let's talk about AMPLIFY Study, where Acalabrutinib is being combined with Venetoclax and Obinutuzumab. John, this looks very exciting. Your thoughts on design and its findings?
AMPLIFY was an exciting study to read out for the first time this year at ASH just a few days ago. This was exciting for practitioners in the US because it might afford and likely will afford the first approval of a oral doublet combination / triplet combination in the United States, in this case with Acalabrutinib. This was a study that looked at 3 arms, Acalabrutinib, Venetoclax, Venetoclax, Obinutuzumab, and against the control chemoimmunotherapy arm of FCR or BR. This excluded patients with deletion 17p because randomizing those patients to chemotherapy is not considered an ethical approach. Those patients were not enrolled or studied. This was 14 cycles of treatment, so 2 cycles of Acalabrutinib lead-in, followed by 12 cycles of Acalabrutinib Venetoclax. The Obinutuzumab also started at the same time that the Acala did in the AVO arm. And a really powerful, important study on a few things. One, and the primary endpoint here was looking at Acalabrutinib Venetoclax against chemotherapy. That way, all of the power and statistical evaluations were essentially looking at AV versus chemoimmunotherapy and not to be washed out by the AVO components of this, though they have hierarchical evaluations of the triplet combination against chemo as well. And what we saw is that Acalabrutinib Venetoclax met its primary endpoint by having an improved progression-free survival, as you can see at this IRC 36-month landmarked time point of 76.5 months versus 66.5 months in the chemoimmunotherapy arm. And when you looked at the AVO arm, seeing this signal where adding the antibody can actually improve outcomes in terms of MRD negativity, complete remission rates, and that typically will translate into, with any fixed duration, will translate into a longer-term progression-free survival benefit. So we see the AVO arm perform the best of the 3 arms at a cost of toxicity. No overall survival difference was really noted at any of these time points. And, I think with the analysis of COVID and things like that, we can talk about that, but it's performing very well tolerated in terms of its toxicity profile comparatively to what we might have seen with ibrutinib and venetoclax. Well managed. Most patients, again, younger patient, more fit population. I think the median age was in the mid 60s on this study. For the most part, patients completed all of the 14 cycles and very few dose reductions or discontinuations of either or both of the agents of the AV arms.
Right, Joel. Thanks so much for going over that. And rather, this is certainly an exciting study, but as you stated, it comes at a toxicity cost. And especially when you talk about AVO, where you have exhausted everything up front, what is to one use in second line approach, especially when we've been going back and forth if we have utilized Ven in front line and then we are relying on BTK in the second line and vice versa. Are you utilizing any of this approach or still sticking with what we have at hand?
Yeah, so the triplet, I think, can be nice for a small subset of patients. For those higher risk patients, we do see some improvement in outcomes. And, I think right now it's a discussion that has to be had with the patient, because what we saw in this study is that the addition of the antibody did have increased infection deaths, particularly related to COVID. And it's important to remember that this study started to accrue right when COVID hit, in the meat of 2020, in the meat of 2021, when was the vast majority of these patients were accruing. It seemed like most of these toxicities and deaths were occurring while on. They did speak to vaccination impact, that most of the patients who had died had been not vaccinated with the available COVID vaccines. They did some sensitivity analysis that if you took COVID out of the picture, the AVO arm started to look really good. The AV did not have as many infectious deaths, which is a positive for that regimen. The antibody is really adding some immunosuppression here. And I think there was only 8 COVID deaths compared to like 22 or something in the chemotherapy arm and the AVO arm. So a dramatic decrease in that infectious toxicity. So an advantage of AV with the cost of maybe less efficacy, less MRD negativity, translates into slightly lower PFS. No overall survival difference is being noted between the AV or AVO arms. Overall survival starts to look good for all the arms. It's a discussion that will need to be had, but I think what's nice is that AV looks to compare historically well to our other fixed duration approaches like Venetoclax, Obinutuzumab, and offers a new treatment that is well tolerated. You don't have to deal with the Obinutuzumab lead-in and the toxicities that come with that. And I think it's a welcome choice for community practitioners, for myself, and in the academic world, seeing CLL patients, that it gives us now some freedom of choice of which approach do we want to take, and a well-tolerated approach. The second question that you had about using all of the drugs in that frontline setting, we don't see much data from this data set about retreatments and mutation analyses and things like that. It's just a little too early. We don't have much information about that, but we have learned from other studies like Captivate, which looked at ibrutinib and venetoclax, and GLOW, and some of the studies with ibrutinib, is that upon relapse, we're not seeing resistant mutations. We're seeing patients being able to go back on mostly from most of the data is just continuous therapy BTK inhibitors, but they're responding and responding for a very long time. They retain sensitivity. My experience enrolling and participating in the Captivate study has led me to believe that these doublets and triplets are very safe because we're not necessarily causing harm to our patient. We are able to salvage them. And if anything, you can argue that it may actually improve the resistance profile because now you're pulsing the patient with treatment. There's less evolutionary pressure to break through. And in fact, it may maintain sensitivity over multiple courses of treatment over the next 10 plus years.
Well, exciting times. We'll see how it all turns out once we have longer term data on this. John, from one study to the other, where the combination is very similar, which is a BTK inhibitor, now with BCL2, here are the cases Zanubrutinib and Sonrotoclax.
Yeah, so this is an exciting study. Sonrotoclax is a new BCL2 inhibitor that seems to be pretty potent in terms of ability to inhibit BCL2. It seems to have a unique property to be able to actually inhibit mutated BCL2. It is being trialed in combination with Zanubrutinib against our other current standard first fixed duration Venetoclax and Obinutuzumab. This study is just ongoing. It's only been presented as a study in progress. But at ASH this year, we did see some of the preliminary data of Zanubrutinib and Sonrotoclax in treatment-naive patients of about 40 or 50 or somewhere around there. Maybe it's like 60. We saw really impressive data in terms of response rates and MRD negativity. So almost 100% of the patients, I believe, showed an MRD negative remission at the end of treatment. It's an exciting compound, and we look forward to this study, which is rapidly accruing to hopefully get some top-line data in another couple of years to potentially have this as an approved option over our fixed duration approach. And this will help us identify who can benefit from the antibody, who might be able to benefit from an all-oral therapy. So also a very important study because, the study before we showed here had the AVO versus AV, but it didn't have the other standard fixed duration. And so we haven't had that perfect study yet that can answer all of the questions, unfortunately. But nonetheless, as we piece these together over the years, we'll be able to find the subgroups that might benefit with one approach versus others.
Okay, we have some good options up front, be it sequencing or using everything up front, but then there is still a small subset patient population that will progress through all this. Now we also have Lysosol that's approved. Lysosol is being used with other PTK inhibitors as well as a combination. John, as a community oncologist, CAR T in CLL, your thoughts here?
Yeah, I mean, so it's a welcome. I'm so glad it crossed the threshold of being an option for our patients. It's something that, if it works, can be potentially curative for some of the worst patients that we have, the ones that have broken through all of these top drugs that we use, and might actually have high curative potential in those patients that get that response. The unfortunate thing is that only about 20% of patients got that complete remission. It's only important to really look at the complete remission patients because everybody else will eventually progress within 1 to 2 years. Only about 20% of those patients got to that complete remission. So we need some work done in showing how to optimize and improve that. One way to do that is in combination with a BTK inhibitor. In this case, it was Ibrutinib. Ibrutinib has some T cell effects and some immune modulation, which is the BTK wasn't on board for the CLL component. It was really on board to modify the T cell component and to improve that product. And we do see higher response rates. We do see higher CR rates. It pushed it up to about 40% of patients. I think more work needs to be done. It's a great option for patients who are breaking through some of these therapies, those with very high risk disease, because that was definitely represented in these studies, those with deletion 17p, complex karyotype, multiple prior lines of therapy, double exposed or double refractory to BTK and BCL2s. Where to place it in the setting of reversible BTK inhibitors, which has an indication in the same line of therapy after exposure to covalent and BCL2, remains a question and remains uncertain. Toxicities are very, very different. Pirtobrutinib and other reversible BTK inhibitors that are being developed in the space, Pirto being the only one FDA approved, is very easy to reach for. You can get a patient started within 3 to 7 days of writing a prescription and having it delivered. It shows remarkable efficacy. 80% of patients are responding in very high-risk disease. That response in these patients in the fifth line setting, essentially, is limited. It's only about a year and a half to 2 years. Nonetheless, that is a way to get disease control. If you're starting on pirtobrutinib, I think most people would say that's kind of the first reach and go to in any of these progressing patients. That is somebody you need to then start talking to your colleagues in the community centers or to your BMT colleagues doing CAR T, because that's a patient that will potentially and likely need CAR T cell therapy in the very near future. And the logistics there can be complicated, need some lead time, need to be established with those practitioners. And so when the time to strike is right, they can move quickly and get the patient collected and treated appropriately.
Well, exciting times indeed. And I got it at our ASH satellite event. We moderated a session, and the recurrent theme was use of bispecific antibodies and CAR T in heme malignancies, where again, the tie-in for community oncologists to reach out to tertiary and quaternary centers becomes a key here. John, thank you so much for taking the time to cover CLL studies from ASH 2024. For our listeners, let us go over a quick recap. In today's discussion with Dr. John Allan from New York Presbyterian Hospital, we had a chance to focus on a few key studies from ASH 2024. We touched on SEQUOIA update, which led to the approval of Zanubrutinib for CLL in frontline settings as a single agent. Then we had a chance to focus on Acalabrutinib with Venetoclax and ongoing study for Zanubrutinib with another BCL2 inhibitor. Lastly, we discussed the role of CAR T in this space as well.
If combination options with BCL2 inhibitors with BTK inhibitors were to become available, balancing side effects will become very important. Right now, our options are Zanubrutinib or Acalabrutinib, or limited time treatment with Venetoclax with Obinutuzumab in frontline. Thank you for joining us. Make sure to check out our other ASH and SABCS 2024 discussions. We are the Oncology Brothers.